The CUHK Policy Research at Hong Kong IAPS program was established to promote cross-boundary and interdisciplinary collaboration on policy research. We are pleased to present a series of webinars to share the works of our researchers across different faculties on issues related to the pandemic with implications on policy decisions. The first in the webinar series is on bioethical issues arising from the COVID-19 pandemic. Various ethical issues have arisen from the pandemic, including who should receive scarce medical resources, should the utilitarian objective of promoting public health override non-utilitarian values like liberty and autonomy, privacy and confidentiality, transparency and trust, and justice and fairness. How should we determine and whether to adopt the policy of herd immunity, whether and when to reopen the economy, and whether the wearing of masks in public should be made mandatory. These sets of our ethical issues will be addressed in the three presentations today. Our first speaker would be Professor Nancy Jecker, who will be talking about prioritizing frontline workers during the COVID-19 pandemic. She will be followed by Professor Roger Zhong, who will talk about using a public health ethics framework to unpick discrimination in COVID-19 responses. And the third speaker would be Professor Hon Lam Lee, who will be talking about wearing of masks, herd immunity, and reopening of economies, reasoning about value trade-offs. We'll ask all three speakers to give the presentations first before we open for discussion and questions. If you want to ask a question, please send in your question via the chat box, and we will invite each participant to speak one at a time. Okay, without further ado, let us turn to our first speaker, Professor Nancy Jecker, Professor of Ethics and Humanities at the University of Washington Medical School, and she'll be a visiting professor at the CUHK Center for Bioethics starting from September 1st, 2020 for the next 6 months. Professor Jecker received her PhD from the University of Washington. Her research focuses on individual and societal aging, justice, human dignity, medical futility, and global perspectives in philosophy and bioethics. She has published 200 articles and 4 books. Her most recent book is Ending Midlife: Bias, New Values for Old Age. Please welcome Professor Nancy Jecker. Nancy, over to you, please.
Good morning. It's a privilege to participate in this webinar on bioethical issues arising from the COVID-19 pandemic. I'm going to start things off by presenting a series of arguments in support of prioritizing frontline workers during the COVID-19 pandemic. The material that I will be sharing was developed in tandem with 2 US colleagues at Seattle Children's Hospital, Drs. Erin Whiteman and Doug Diekema. So outside of pandemic emergencies, we have in place criteria for allocating scarce resources during emergencies that I suspect are familiar to many of you. And these are standard triage criteria, which are aimed at categories. They instruct providers to allocate scarce medical resources first to patients likely to survive only if they receive a treatment, next to patients likely to survive without a treatment, and finally to patients likely to die even if treated. Notice that standard triage criteria are blind in the sense that equal weight is given to each person's life. There is no direct consideration of factors such as age, social worth, or underlying disease. Underlying disease might factor in if it affects survival, but otherwise not. For example, during the COVID-19 pandemic, A patient with dementia does not receive a lower priority for a ventilator than a healthy patient, but a patient with a chronic lung disease might. With standard triage, emergency physicians and first responders implement distributive criteria that are established in advance. They are not themselves determining criteria for patient selection or rationing at the bedside from one moment to the next. Instead, health professionals advocate for patients within the constraints that are set by a fair distributive scheme. Some algorithms developed in the US during the COVID-19 pandemic extend the same logic of standard triage by creating more nuanced subcategories, which would apply only if the supply of a particular resource, such as ventilators, is exhausted. For example, a typical system might use prognostic indicators to classify patients' chance of survival with treatment as 75 to 100%, 50 to 74%, 25 to 49%, and 0 to 24%. And then among the group likely to survive only with treatment, priority would go to A over B, B over C, and so forth, allowing for more fine-grained allocation priorities. The logic of standard triage is apparent in many other triage tools, which are largely based on its principles. For example, SOFA, the Sequential Organ Failure Assessment Scores, assesses the number and severity of organ failures to rank order patients for intensive care unit admissions. Yet notice that standard triage is designed for short-term, self-limiting situations, such as a mass shooting when there are multiple victims of gun violence, or a natural disaster such as an earthquake. They're not designed for the global pandemic we are now in. And the key difference between self-limiting situations and a pandemic like COVID-19 is that during a pandemic, especially the surge phase of a pandemic, too many patients qualify and are equally likely to benefit from a resource after standard triage criteria are applied. And this triggers the need for some additional selection criteria applied to patients who share a similar prognosis. Without supplementary criteria, health professionals are left to figure out on their own what to do without crisis standards to guide them. This reportedly occurred during the surge phase of the COVID-19 pandemic in Wuhan, China, the Lombardy region of Italy, and New York City. Without additional criteria to prioritize patients with similar prognoses, physicians were left without any standards to apply. In a 2020 survey of directors of US and Canadian bioethics programs, over 1/2 of respondents reported that their affiliated institutions did not have ventilator triage policies for allocating resources among patients who qualify using standard triage. Among those reporting policies, there was substantial heterogeneity, and many omitted guidance on fair implementation. So the question I'd like to pose is, what additional criteria should apply during a pandemic emergency? For example, what additional criteria should guide the allocation of ventilators during the surge phase of the COVID-19 pandemic? We propose that after applying standard triage, if further selection is needed, the first priority should be frontline workers with workplace exposure to infected patients. So this includes not only physicians and nurses, but respiratory therapists and any other healthcare workers required to enter the room while an infected patient is present. The ethical arguments for priority to healthcare personnel on the front lines is threefold. First, prioritizing frontline providers benefits not only those providers, but the many other people they care for during a pandemic, producing what we call a multiplier effect. This argument assumes that the providers who fall ill will recover and continue caring for patients during the pandemic. Of course, patients who suffer acute respiratory distress syndrome and require ventilators for an extended period may take many months or years to recover, experiencing difficulty walking, moving, and even thinking as well as they did before. Yet, given that it remains unclear how long the COVID-19 pandemic will last, providers who survive their illness may be of value during a later stage of the pandemic, especially if other providers fall ill or die, leaving a shortage of essential personnel. A second argument for prioritizing healthcare providers on the front lines is that when they fall ill caring for infected patients, they are harmed in service to society. One way of spelling this out appeals to the metaphor of a social contract. According to this line of reasoning, society grants health professionals privileges in exchange for their agreement to serve us by helping the sick, even at risk to themselves. As part of this contract, society promises to care for healthcare workers if they fall ill. A third and final argument invokes the value of reciprocity. It holds that, contract or not, society is the recipient of numerous benefits from healthcare providers on the front lines. We have a duty, in short, to give back to those who give to us. Notice that the first argument, the one that appeals to a multiplier effect, reflects a limited appeal to social utility. We distinguish between broad and narrow forms of social utility. Broad social utility refers to a person's overall worth to society. It was reportedly used during the 1960s in the US as a basis for allocating kidney dialysis among people in Seattle, when a committee reportedly took into account things like a person's occupation and education. The appeal to a multiplier effect does not sanction the broad and indiscriminate use of social utility of the kind that the Seattle committee reportedly applied. Instead, the argument we propose appeals to narrow social utility. Narrow social utility refers to the short-term value an individual brings to a group during a public health crisis or other emergency. In this argument, short-term value is based on a healthcare worker's special knowledge and skill and their willingness to assume significant risk to carry out essential services. The argument for priority to medical workers has added force in low and middle income countries where healthcare workers are an even more scarce resource and even more difficult to replace. Notice that consistently applying narrow social utility builds into selection criteria a broader rationale, one that extends beyond healthcare workers to non-medical personnel on the front lines. So we argue that the next priority should be essential non-medical personnel, such as custodians who clean and sanitize the rooms of infected patients daily, as well as other non-medical personnel like hospital security who regularly enter the rooms of infected patients to perform vital services. The argument in support of this next priority is also threefold. First, a multiplier effect applies again. Prioritizing these frontline non-medical personnel benefits not only these personnel, but also patients. Second, during a pandemic, frontline non-medical personnel assume risks in service to society. A helpful analogy is a mechanic who keeps military trucks running on the front lines of battle, or a cook who feeds troops. These non-soldiers contribute essential services to society, and the work of others, in this case soldiers, would not be possible without them. A final argument holds that although a custodian or other non-medical worker might be more replaceable than a healthcare worker, it violates respect for the person who is a custodian to view them as fungible and replaceable by others. Instead, each individual deserves to be regarded as an end rather than merely a means to others' ends. It might be claimed that someone who serves society outside a medical setting also plays a vital role during a crisis. For example, bus drivers, grocery clerks, and teachers also benefit society. In reply, while many people contribute essential services to society, Narrow social worth is not based only on social contributions, but also on the level of risk a person assumes. While bus drivers take more risks than people who do not leave home, they take fewer risks than people like the custodian or respiratory therapists who are in the same room as infected patients. Both assuming substantial risk and benefiting society are necessary to warrant priority for scarce resources. In conclusion, providers should advocate for patients under a fair allocation scheme rather than rationing from one moment to the next. They should appeal to allocation criteria established in advance. And during the surge phase of a global pandemic, after standard triage criteria are applied, if too many patients qualify, priority should go to frontline healthcare workers and non-medical personnel. I want to thank you very much for your attention.
Thank you, Nancy. Our next speaker is Professor Roger Zhong. And Professor Zhong received his PhD from the University of Hong Kong. His research interests include health equity and social epidemiology and aging-related research. He's the founding associate director of the CUHK Institute of Health Equity, established in January 2020, under the co-directorship of Sir Professor Michael Marmot, Professor Yi-Kei Yeo, and Professor Jean Wu. And Roger is also assistant professor at JC, the Jockey Club School of Public Health and Primary Care, CUHK. Roger, please.
Thank you very much, Fanny. Thank you very much, Professor Jekka. So it has been my honor to present my paper, which is based on an open peer commentary published in the American Journal of Bioethics special issue on COVID-19, in tandem with Alexander Erler, Han Nam Lee, who's going to be another speaker for today, and also Derek Au, who's the director of the Center for Bioethics at CUHK. So my topic is using a public health ethics framework to unpick discrimination in COVID-19 responses. So this is the paper, as I have already mentioned. So here's a little bit of a background. So we all know that COVID-19 is a pandemic which is going on rampant still to this very moment. And public health related laws and policies and measures have been implemented with the primary purpose of promoting, restoring, and maintaining health of the public. And this is understood, widely understood as the main goals of public health. And this is the WHO definition of public health. So the health of the public is taken to be worth promoting and worth protecting because it is the right thing to do. And I believe everybody believes in that. So in other words, what is right and what is wrong is an ethical consideration, right? And that is central to achieving the goals of public health. Now, with maximizing the benefits and minimizing the harms to the health of the public being taken as the prima facie warrant, the ethical considerations that are most commonly recognized to instantiate the goal of public health can be described as having a broadly utilitarian nature, as highlighted. I'm going to talk about what we mean by that in a bit. And on the flip side, there are other important non-utilitarian ethical considerations that are also relevant, like, for example, liberty and autonomy of actions, privacy and confidentiality, transparency and disclosure of important information, trust building, commitment keeping, and also justice and fairness, and also equity. Now, we are actually following a more public health oriented construal of the term utility. While we are acknowledging that there are other utilitarian accounts that seek to recognize liberty and autonomy and justice and fairness, all these in utilitarian terms, but this is not where how we're going to understand it today. So we're going to put it into utilitarian term, meaning maximizing the health and minimizing the harm to the public health. to the health of the public versus other non-utilitarian considerations that are not really directly related to health, but are still very important. So as Ruth Thaden and Shibaya put it in 2016, Public Health Ethics deals primarily with the moral foundations and justifications for public health, the various ethical challenges raised by limited resources for promoting health, real or perceived tensions. So as you can see it, conflicts among all these different ethical considerations do arise, and especially during such a parlous time of COVID-19. So in combating COVID-19, it is not uncommon, meaning quite common, for disease prevention to be used as a justification for measures initiated by non-professional members of the general public, and also maximization of health gains, and also risk minimization, sometimes at all cost, where the policies are stringent or even draconian, to be used as justifications for strategies by policymakers, right? So we hear a lot in the news, in the media, from the government, from the officials, that we need to protect people's health during this pandemic. And in effect, when such a utilitarian objective is regarded as incontestable and probably even the single most important one worth pursuing, other non-utilitarian ethical considerations would be heavily truncated, to say the least, and in turn adversely affecting the rights and liberty of the people at stake. So therefore, a public health ethics framework that tries and attempts to resolve the potential conflicts between utilitarian and non-utilitarian ethical considerations is much needed. This is the argument of this paper. And we do know that there is no consensus about the methods and content of public health ethics. But if we look at the literature, Childress in 2002, et al. In 2002, they did provide a conceptual framework of public health ethics in which they specifically try to resolve the conflict between this utilitarian objective of promoting public health and also the other non-utilitarian values in particular cases, right? So what they try to do is to propose five, they call it the 5 essential justificatory conditions to help determine whether the utilitarian objective of public health warrants overriding the other non-utilitarian values. Example, which I've already given before in particular cases. And we argue that this is very much aligned with what is happening now with the COVID-19. So what are those 5 essential justificatory conditions? Number 1, effectiveness. In other words, whether such measure, such policy is effective in protecting public health. That is, the priority. If it's not effective, then, it is out of the question. Number 2, proportionality. In other words, whether the probable benefits toward the public's health outweigh the harms that would be done onto them. Proportionality. Number 3, they call it necessity or sometimes essentiality. In other words, the way that the questions that they ask is whether there is any alternative strategy that is less morally troubling that is available. So if there is an alternative strategy that is less morally troubling but still proportionate, still effective, then we say that maybe the proposed measure or strategy or policy isn't necessary, isn't essential, because there's an alternative that is better. Now, and when the proposed strategy satisfies the first 3 conditions, then we look at this criteria called least infringement. In other words, the infringement of the general ethical considerations, especially the other non-utilitarian ones, should still be minimized. The infringement on people's liberty, autonomy, confidentiality, privacy, and justice, and equity, and fairness, all these should still be minimized. And last but not least, public justification. In other words, if all these criteria are met, the responsibility for the agents to implement the strategy should be emphasized, and they should have the responsibility to explain to the public and to convince the public that this is justified, this is ethical or ethically justified. And these criteria, these essential criteria are met. While these may not be the only criteria, but these are the essential justificatory conditions as argued in the paper. Now, I just throw this picture in because this is quite a famous picture which garnered quite a lot of attention on July 29th, if I remember correctly, when the epidemic is at the peak right around here in Hong Kong, right? So what happened here is that the government actually implemented the mandatory lockdown of the restaurants during lunchtime. And suddenly a lot of people realized that a lot of the employees, the workers, do not actually have an office to enjoy or to have their lunch, right? So this is what happened on a rainy day on July 29th, where they all took out their lunch boxes and eat outside, and they mingle with each other, and they were not sitting, or they weren't really carrying social distancing effectively here, right? So this raises a lot of eyeballs and actually catches a lot of people's attention because it is one picture but captures something very deep within our human emotion or ethical understanding. Really taps into our moral senses that this looks very unethical, right? So this is something that we can look at. This is not something that this is not the case that I've used in my paper, but we can try to apply we're arguing here is that we should try to apply an ethical framework to scrutinize different kinds of policies and measures and tactics and strategies. So this is mandatory lockdown of restaurants during lunchtime. So the questions to be asked is whether it's effective in protecting people's health. Doesn't seem like it because they're still mingling with each other. Whether it's proportional in that the benefits outweigh the harms. Whether it's necessary in that there is no alternative that is less morally troubling. And whether other ethical considerations are less infringed or least infringed, and whether this is justified to the public who are being affected. So what happened after this is that the aftermath is the government changed the policy. And it is kind of like a power of a media photo, so to speak. So policy, what we want to argue is that the policy that may be less morally troubling is one that takes into account social economic inequalities and also social determinants of health. Right? So obviously this policy that was implemented has not really taken social determinants of health into account. So by social determinants of health, I'm talking about this framework. This is an updated 2010 framework from the WHO, which looks into the social determinants of health. I'm not going to go into details here, but what we're trying to say is that there are social aspects and social factors that gave rise to our health outcomes. In the paper, we also distinguish between the political public and the general public. We are arguing that the public health ethics is not only used to hold the political public responsible, but they are very much responsible because they possess political and policing powers as well as resources to influence essential public health functions and also implement policies that affect all people that it represents. And it is precisely the possession of such powers and resources that raises important ethical questions as to where the limits to these powers lie, whether the government policies and interventions are justified, and whether these powers are exercised equally and fairly across members of the society, right? But at the same time, the general public and their corresponding collective and social community actions should also be considered because they do have considerable impact on public health. And therefore, their actions cannot elude the scrutiny of public health ethics. So as the US Institute of Medicine, now called National Academy of Medicine, put it quite eloquently, I would say, public health is what we as a society do collectively to assure the conditions in which people can be healthy. It's not just talking about the government or the political public, but we also include the general public. So this is something that is important to take home. So in conclusion, it is pertinent to consider public health ethics in the discussion of COVID-19 prevention and intervention strategies, especially in today's highly globalized world where infectious diseases know no national or geographical border or boundary. So in this commentary, we described and we argue that we should apply a conceptual framework of public health ethics where in Childress et al.'s conceptual framework, they proposed 5 justificatory conditions for utilitarian considerations to override the non-utilitarian ones. In our attempt to apply this framework to today's COVID-19 situation, we also illustrated how discrimination can be entailed in COVID-19 responses when other non-utilitarian values were not adequately considered, just as shown in the photo that I have just presented. So I would just like to conclude with a quote by Judith Butler. Social and economic inequality will make sure that the virus, COVID-19, discriminates. The virus alone does not discriminate, but we humans surely do, formed and animated as we are by the interlocking powers of nationalism, racism, xenophobia, and also capitalism. So these are the references that I've used in my talk, and this is my contact. So this is Sir Michael Marmot and Jean Wu, who's the co-directors of the newly established Institute of Health Equity, and this is the kind of work that we do in the Institute. In addition to public health ethics, we also look at the social epidemiology side of health equity. Thank you very much.
Thank you, Roger. Our last speaker is Professor Hon Nam Lee, professor at the Department of Philosophy at CUHK and the Deputy Director of the CUHK Center for Bioethics. Professor Lee received his PhD from Cornell University. His research interests include practical ethics, ethics, political philosophy, and philosophy of law. He has been an academic visitor to All Souls College in Oxford, a visiting scholar at Cornell University, a visiting fellow at Robinson College, Cambridge, and the Fulbright visiting senior scholar at Harvard University. He's currently working on a book in practical ethics. May I invite Hon Nam Lee to talk about reopening economies during COVID-19 pandemic, reasoning about value trade-offs. Hon Nam, please.
Thank you. Thank you, Professor Fanny Zhang, for inviting me to speak here today. I'm very glad to be able to do that. Okay, so the topic for my talk today is wearing of masks, herd immunity, and the reopening of economies, reasoning about value trade-offs. And below here is the my email address, and I would welcome any comment or criticisms on my talk, on my paper. So it's hornlamley@hotmail.com. Okay. So this paper on which my presentation is based has been published last month in the American Journal of Bioethics, and the co-author you have already seen, and that is Professor Nancy Jacker and Professor Roger Chung. Okay, we wrote this paper together. Okay, so today I'm going to talk about 3 bioethical issues. And these issues are, should wearing of mask in public be made mandatory? Is the policy of herd immunity ethically sound? And the third one is, how should we look at the reopening of economies from an ethical perspective? So today my talk is not an empirical one, rather is a philosophical talk, and it can be seen as an exercise in applied ethics. By this I mean, I shall use what I consider the most plausible ethical theory and try to apply it to each of those 3 issues. Also today I will look at 3 perspectives, 3 ethical perspectives to consider the 3 issues. And they are, first of all, the majority rule, and then utilitarianism, and finally, contractualism. Okay, first, the majority rule. Okay, what does it say? What do we actually mean by the majority rule? Well, I mean, the simple formulation is simply that we should do what the majority say. Now, in politics, the majority rule might translate into a form of democracy, right? I mean, isn't democracy a majority rule? Now, I'm not against democracy. In the best form of democracy, namely deliberative democracy, it says that we should first deliberate. And now we are at the stage of deliberation, right? We are not at the stage of voting. So at the stage of deliberation, we should do better than just counting the number of those in favor of a policy and also those who are against it. Okay, so you may wonder why. How can we do better? Okay. Now consider this example. Suppose we can save either one person's life or else alleviate 10 people's headache, but not both. Okay, which group should we help? This is a typical philosopher's example, right? I mean, rarely do we come right into this kind of example, but I hope this example make a point. Okay, so the point it makes is this: if we rely on the majority rule, and if 10 people say, alleviate our headaches, whereas one other person says, save me, okay? Assuming that all of them care only about themselves, then we should alleviate the headache instead of saving a life. This conclusion is clearly unacceptable, right? Because that's not what we think is the right thing to do. We should clearly save that person's life, not simply count the number of people who are in favor of themselves. So we need a better view, okay? Okay, so the second view is utilitarianism. Okay, utilitarianism is a very dominant ethical theory in the Western world for more than a century. And it's only in the past 40 years or so that it has come into question. Okay, utilitarianism says that it is ethically correct to maximize utility. And what's that mean? What that means is to promote the best consequences. Now, according to this theory, we should take account of not only the number of people for or against a policy, but also the extent to which they are each affected by the policy. So in the headache example, utilitarianism says that a human being's life is more important than 10 headaches put together. Why? Because a human being's life would have more utility than curing 10 headaches. Therefore, we should save a life rather than alleviate 10 headaches. So this conclusion is obviously correct. But although it is correct, although utilitarianism come to the correct conclusion in this case, it is pragmatic. Why utilitarianism is mistaken? Now consider another example. Either we can save one life or else alleviate a huge number of minor headaches, okay, each suffered by a different person. Okay, let's say we can alleviate 1 million minor headaches. Which group should we help? Now, utilitarianism would have to say this, that we should alleviate the headaches if those having headaches are sufficiently numerous. Suppose 1 million people suffering a headache, or 10 million people, or 1 billion people. Okay, there's a point, okay? There has to be a point beyond which we have to save the headache, okay? However, there's some consensus among philosophers and ethicists that we should save someone's life, okay, instead of alleviating even millions of minor headaches. Okay, I hope you share the same intuition, all right? So if utilitarianism is mistaken, we come to the third and hopefully it's a better view. Okay, the name of this is called contractualism. It has to do with a contract. Well, what does it say? It says that we should save one life instead of alleviating millions of headaches, okay, in case we cannot help both group of people. Why? I mean, there are certain theories, and for example, one idea is how can we justify to the person who would die that we are alleviating other people's headache instead of saving him or her, but we cannot justify to this person. Okay, so I will not actually go into the theory of contractualism, but only what it recommends. Why? Because for one thing, we don't have time. Okay, if you are interested in exploring into this theory, I recommend you to read Professor T.M. Scannon's book, important book, called What We Owe to Each Other, especially chapter 4 and 5. Professor Scannon was here at the Center for Bioethics last year. If you want to read something easier, I myself have summarized the theory and applied it to the problem of capital punishment in the paper called Contractualism and the Death Penalty in the journal called Criminal Justice Ethics. Okay, and that was published in 2017. So I said we're doing applied ethics, right? So let's apply, the ethical theory in different kind of cases. The first case is wearing of masks. Okay, assuming that wearing of masks in public is effective against the spread of deadly virus, we should all wear a mask when we go out. Suppose 1 million people each wearing a mask in public for 8 hours will save a life. Okay, should we wear a mask, or should their minor discomfort outweigh the life? Right, we're talking about 1 million people, right? Now, given the results from the headache example that we have just gone through, it should be obvious that the only ethically acceptable conclusion is every one of these million people should wear a mask in public, right? Because a minor discomfort can help save one person's life. I assume that wearing a mask for 8 hours is not more discomfortable than having a minor headache for the same period of time. But note that there's an important difference between these two cases. In the headache example, if we alleviate the headaches, someone will die, right? Because you're not saving this person, right? You're curing the headache. But his or her death will not cause further death. On the other hand, in the mask example, if you allow people not to wear masks in the public, someone will die, but this will likely cause more death through transmission of virus. I mean, if one person dies, statistics says that probably 40 or 50% would have gotten sick. The ethical force of requiring people to wear a mask in public is therefore even stronger than the force of saving someone's life in the headache example. Okay, so that was an easy case. We come to a slightly more difficult case now, herd immunity. By herd immunity, I mean the policy of letting 60 to 90% of the people contract the virus naturally and subsequently develop immunity to it. Now, Sweden has adopted a policy that is close to it, if not exactly the same, as herd immunity. Now, no one knows, I take it, of the long-term effect of herd immunity compared with other strategies. But as of today, the number of people who contracted the virus and also those who subsequently die in Sweden are as follows. We're comparing Sweden, which used a method that is pretty close, if not identical, to herd immunity versus its neighbor, Norway and Denmark, and they don't use herd immunity. Now, these figures suggest that in the case of Sweden, total number of cases per million, total number of contraction of the virus is 8,000 something. Total number of deaths per million is 500 something. You can see quite clearly that the total number of cases per million in Sweden is much higher than in Norway and Denmark, and also the number of deaths. Okay. One important consideration in the Swedish adopting of this policy was to protect the economy. So another possible consideration is that Sweden might fare better if there's a third, fourth, fifth, or sixth wave. I guess that's one possible consideration, right? However, if a vaccine becomes available in the next 6 to 12 months, probably more people per million will have died in Sweden than in the neighboring countries such as Norway and Denmark. Okay. So the question is, suppose herd immunity is better for the economy, but will cause more deaths. Is herd immunity ethically justified? Now, again, using the headache example, it seems that people's lives are more important than the economy, right? Because, this, of course, that is maybe a little bit simplistic, but I will try to be less simplistic a little bit later. But now that means the 5,000 deaths in Sweden, over and above the death in Norway or Denmark, cannot be justified in the name of good for the economy, if indeed this is good for the economy. Now, I said I qualify with if indeed, because later on I would look at some views by people at the Harvard Medical School, and they query this view. Now, I've talked about contractualism, right? However, contractualism needs to be modified if we are going to do justice to the ethical phenomenon, as it were. So far we have been looking at minor headaches, right? So surely not all kinds of harm are like minor headaches. As a result of lockdown in many countries, more people have committed suicide or attempted to do so, and many others have plunged into depression. Also, surgeries have been cancelled or postponed. At Boston's Brigham and Women's Hospital, 50% of all cancer operations have been arranged to treat patients with life-threatening illnesses. Worldwide, more than 28 million operations were cancelled or postponed during the peak 12 months of disruption due to the pandemic. But there's a big gap between deaths on the one hand and minor headaches on the other, right? How does contractualism deal with comparisons between saving life and curing serious illnesses? Okay. Now, another philosopher's question. between saving someone's life and alternatively curing or preventing 2,000 cases of blindness, which group should we help? Answer, we should save 2,000 people from getting blind to prevent their blindness. Okay, the contractualist idea is this: the person who would die cannot now object because numerous people would suffer harm, though not as bad as death, but is nearly as bad as death. So blindness is relevant to death, but minor headaches is not relevant when we are considering life and death. So unlike minor headaches, blindness is ethically relevant, even if a life is at stake. The ethically correct thing to do in this case is to prevent 2,000 cases of blindness. And well, we cannot go into a theory, right, because of the time constraint. And but I myself believe contractualism has the resources to arrive at this conclusion. Now, application 3, reopening of economies. The issue of reopening of economies is more complicated than wearing a mask or the topic of herd immunity. Why? Because it involves complex empirical issues. The issues may be different from different parts of the world. So the question is sometimes put as the health of the patients versus the health of the economy. Now, there's one empirical issue here, right? And that is what should be done to minimize deaths, okay? So several months ago, I don't remember which month, whether it's March or April, according to some scientists at Harvard Medical School, they say there's no conflict between lockdown and the economy. There's no conflict between the health of the patient and the health of the economy. Why? Because the reason is that lockdown will lead to a rebirth of the economy faster than if there had been no lockdown. So probably Wuhan was the example to support this view, and perhaps New York City is another example. Now, we all know that various measures about lockdown or partial lockdown, closing of restaurants and cinemas and so on, will help control COVID-19, right? But those are the positive impacts. Now, what are the negative impacts? Okay, so I've listed 7 different types of negative impacts. The first is tens of millions of people, of employees in the world got laid off. Second, hundreds of thousands of businesses were closed. Hundreds of thousands of people became mentally ill. And numerous people committed suicide or attempted to do so. Medical appointments, including urgent ones, had to be postponed or canceled. Health, family, friendship, etc. also suffer. And home office bring inconvenience to countless people. Although I know some people like home office. So I'm going to consider 4 different cases.
Sorry, Honam, you only have 3 minutes left.
Okay, thank you. So I'll consider 4 different cases. Yeah, I'll be done in 2 minutes. Okay, the first is loss of business, jobs and money on the one hand versus loss of life, okay? So this is a simplified picture, of course. So if lockdown means only loss of money or jobs or business only, this by itself cannot outweigh any lives, okay? Unless the lack of money or loss of money causes other severe problems. Right. Second case is mental illness versus loss of lives, right? Okay, if there's no lockdown, it may cause more people to die. If there is, some people may have mental illness. Now, numerous cases of severe mental illness can outweigh a life. Okay, recall the blindness example. Okay, suicide versus loss of life. A certain number of cases of suicide, okay, can outweigh a life, okay. I assume that suicide, well, if it's actual suicide, is as bad as blindness, or probably even worse than the blindness, right? An attempted suicide could eventually lead to actual suicide, right? Successful suicide. So the fourth case is loss of life because of the postponement of operations versus the loss of a life if there's no lockdown. Okay, loss of numerous lives because of postponement of urgent operation can outweigh a life. So what I'm trying to say is this is somewhat messy picture, okay, obviously. I'm trying to say that we really have to consider different kind of cases. And there's also an oversimplification, right? I mean, because the Harvard Medical School people, there's no conflict between lockdown and the health of the patients, and health of the patient and the health of the economy. Okay, to summarize, contracture success, no number of minor harms can outweigh the most serious harms. Okay, for example, no number of headaches can outweigh a life. However, numerous cases of a serious harm like blindness, okay, or suicide or attempted suicide can outweigh the most serious harm. Okay, thank you very much.
Thank you very much, Han Nam. Well, this webinar has been recorded and will be available on the archive of the Policy Research at Hong Kong IAPS website. And the speakers has also kindly agreed to share the published articles that they mentioned in the webinar. And the articles will also be uploaded on our website. So thank you very much for joining this webinar, and I'd like to thank our three speakers for their very enlightening presentations and discussion.